Hello, my name is Dirk Larson, and I'm a principal biostatistician at the Mayo Clinic. Today, I will be talking about propensity scores in orthopedic research. Orthopedic studies typically involve comparing two or more groups of patients based on implant type, surgical procedure, or patient characteristics. If patients are randomly assigned to the study groups, as in a randomized trial, they will be similar to each other with respect to measured and unmeasured characteristics. However, orthopedic studies are often based on non-randomized retrospective cohorts. Patients in the comparison groups differ in demographics, comorbidities, and other characteristics. Therefore, comparisons are subject to treatment selection bias and confounding. Here, a propensity score is a valuable tool that can be used to balance patient characteristics, minimizing potential bias and confounding. In this video, I will explain what a propensity score is, how they are created, and different ways in which they can be used to reduce bias and confounding. A propensity score is a numerical value representing the probability that a given patient received a surgical procedure, medical intervention, or exposure based on a known set of characteristics. For example, consider a study comparing patients who underwent total hip arthroplasty using a dual mobility construct to patients who received a standard cup and liner. In this study, a propensity score would represent the probability that a patient received a dual mobility implant as opposed to a standard cup and liner based on patient characteristics and other factors known at the time of surgery. Patients with similar propensity score values will have similar distributions of the variables used to create the propensity score, no matter which study group they are in. Thus, comparing patients with similar scores approximates the effect of randomizing patients to the different study groups. Typically, propensity scores are created using logistic regression. The dependent variable in the model is the factor noting the study groups that will be compared. For example, total hip arthroplasty using a dual mobility implant versus a standard design. The independent variables are the potential confounders, that is, variables associated with the patient being in one group versus the other that are also associated with the study outcome. When creating these scores, it is important to remember to carefully select the independent or explanatory variables, ideally with input from an experienced orthopedic surgeon with subject matter expertise. The independent variables should be associated with both the surgical treatment or exposure and the study outcome. Carefully consider the variables to be included in the model to make sure that potentially important variables are not excluded. It is better to be overly inclusive than restrictive when selecting the explanatory variables in the model. Generally, overfitting is not a concern when developing a propensity score. Once the score is created, there are several ways in which they can be utilized. This video will discuss these four applications: covariate adjustment, stratification, matching, and weighting. Perhaps the simplest application is covariate adjustment in a statistical model. This involves including the propensity score as an additional independent variable in a model containing the study outcome as the dependent variable and the group or treatment indicator as an independent variable. This is advantageous compared to directly adjusting by including several covariates in a model, especially when the sample size or number of outcome events is low. But this approach has limitations, such as the inability to assess for balance between study groups, limited bias reduction, and increased residual confounding compared to other methods. Another approach is stratification. This is done by grouping patients from both study groups into separate bins, or strata, based on the value of their propensity scores. Within each strata, patients will have similar propensity score values, and hence will be similar with respect to the variables used to develop the score. Comparisons of the study groups are then performed separately within each strata, and an overall estimate is generated by taking a weighted average of the strata-specific results. Stratification provides for flexibility in the analysis and may show patterns among the strata that are not identified by other methods. Stratification also utilizes all the study data, unlike matching, which may exclude some patients. However, the disadvantages of stratification include the complexity of combining the strata-specific estimates and the limited bias reduction compared to other methods. Another application is matching. Patients in one study group are matched to patients in the other study group based on the values of their propensity scores. If one comparison group has more patients than the other comparison group, the unmatched patients are excluded. Also, the researcher may choose to exclude patients who are not matched sufficiently well. The patients in the resulting matched groups will have similar distributions of the variables used in the creation of the score. The two matched groups are then directly compared to each other with respect to the study outcome. Successful matching creates balanced cohorts which can be directly compared using standard techniques. However, propensity score matching has limitations. If one study group is larger than the other study group, not all patients will be matched and will be excluded from the study. Matching results may not be consistent across all matched pairs of patients. Some matched pairs may be more closely matched than others, resulting in less balance. Also, the researcher must decide the extent of the difference to allow in the matching and may possibly exclude some pairs that are not well matched, potentially introducing selection bias and model dependence. The last method this video will discuss is weighting. In this approach, propensity scores are used to create weights, which are then applied to the data to yield a balanced comparison. Two effective weighting strategies are inverse probability of treatment weighting, or IPTW, and overlap weighting. IPTW weights patients by the inverse of the probability of receiving one surgical treatment or exposure versus another, whereas overlap weighting weights patients by the probability of being in the opposite group. To clarify these techniques, consider this example. In a retrospective study of patients undergoing primary total hip arthroplasty, patients who received an extended course of antibiotic prophylaxis will be compared to patients who received standard antibiotic prophylaxis. A propensity score is created representing the probability that a patient received an extended course of antibiotic prophylaxis. Using IPTW, patients in the extended antibiotic group will be weighted by 1 over the propensity score, while patients in the standard antibiotic group will be weighted by 1 over 1 minus the propensity score. In contrast, if overlap weighting is used, patients in the extended antibiotic group will be weighted by 1 minus the propensity score, while patients in the standard antibiotic group will be weighted by the propensity score. The result of these weighting techniques is that patients who are less likely to be in the comparison group of interest are upweighted, and patients who are more likely to be in the comparison group of interest are downweighted. This effectively balances the influence of individual characteristics and other factors on patient selection and reduces bias and confounding. If good balance is achieved, the resulting weighted sample approximates the effect of randomization. It is important to remember that propensity scores very close to either 0 or 1 will yield large inverse probability of treatment weights for the treated and untreated groups, respectively. Extremely large weights may have a negative impact on the analysis results, including bias and increased variability of the estimated treatment effect. These issues can be resolved by modifying the weights using methods such as trimming, truncation, and stabilization. Of note, overlap weights do not yield extremely large values in the way that inverse probability weighting might. After the propensity score has been generated and applied using either stratification, matching, or weighting, it is important to evaluate the improvement in balance between the study groups. This can be performed by calculating the standardized differences between the comparison groups for each variable used to create the score. Differences are calculated separately before and after applying the propensity scores and are often examined graphically. Standardized differences less than 0.1 or 10% are generally considered to indicate good balance. Propensity score weighting is a valuable and effective approach to reduce bias and confounding. It utilizes all study subjects and is easy to implement, resulting in improved balance across study groups. It is also flexible and can be used with different analysis methods. However, it should be noted that extreme weights may have a negative impact, but this issue may be resolved using trimming, truncation, and stabilization. In conclusion, here are some guidelines for utilizing propensity scores to eliminate bias and confounding. When comparing non-randomized groups, potential sources of bias and confounding should be identified and acknowledged. The creation and use of a propensity score should be considered as a possible tool to minimize confounding and treatment selection bias in studies comparing non-randomized groups. When developing a propensity score model, the explanatory variables should be carefully identified with critical input from an experienced orthopedic surgeon. Explanatory variables should be known at baseline and should be potentially associated with both treatment selection and the outcome. Propensity score models may contain many explanatory variables with little concern for overfitting. There are several options for applying the propensity score in the analysis. Weighting is perhaps the most flexible and should be considered the primary option. Evaluate the change in balance between the comparison groups after applying the score prior to performing the analysis of the study outcome. And finally, use analysis techniques that are appropriate for the type of propensity score application that was used.